Category 2 is the most common category that you'll see in an SOT practice, and of course it defines the most common patients seen in chiropractic offices pretty much everywhere. Category 2 is sometimes called sacroiliac weight-bearing dysfunction, which is a very general term. It doesn't point to a specific listing like a PI or an AS or an IN or an EX. It's just a generalization. It's usually found much worse on one side than the other. For every category of patient in SOT, there's a flow of procedures. And for category 2, we start with checking the lower extremity, checking the psoas and iliofemoral areas, checking something called the sacral cup and palpating the trap fibers. I would also throw in C1 and L5. I have it on this chart down here as step 3 on the right, but you could check it right off the bat. Then we would determine if the patient has some trigger points that align with supine leg length analysis, and that's called UMS and LLL. And if they do, we can use the SOT blocks to enable the patient to self-correct their SI weight-bearing problem. And I'll get into how you use those blocks. If they don't have these UMS and LLL trigger points, I would go back and see if they have C1 and L5. What I've done lately in lab is I teach you all how to check that right at the very beginning. If they have UMS, LLL, you block them. If they don't have it, even after you've checked out and adjusted C1 or L5, if they needed it, this is not going to be a category 2 patient that you can use blocks on. The SOT blocks are inappropriate for some category 2s, or they might be just part of the correction for most patients who are category 2. Down here at the bottom, near the bottom, we say strong arm fossa. Well, category 2 people will show a weak arm fossa. I covered that last week. When you put them on the blocks, you're waiting for the weak arm fossa to strengthen. So there are 2 requirements for using SOT blocks on a category 2 patient. Number 1, they have to have a weak arm fossa to start with. And number 2, they have to display the specific trigger points lined up with leg length properly. And that's called UMS, or upper medial short, and LLL, lower lateral long. At the end, you can do stair-stepping in figure 8 to find a cervical restriction and mobilize it. You can also balance the legs doing a procedure called long leg, short leg. And you can either automatically or with a specific indicator do a cranial procedure called basic 2. I would usually wait near the end to do basic 2. This is a picture of all the pelvic ligaments from behind, and there's a lot of them. The ones we're most concerned with in category 2 are over to the right near the upper part, and it's called the interosseous sacroiliac ligament. It runs between the pelvis, between the ilium and the sacrum, and it very much virtually holds the ilium and sacrum together. An unusual anatomical fact about the SI joint is it's non-voluntary. There's not one muscle that originates on ilium and inserts into sacrum, or vice versa. The only way you can move the SI joint is pretty much the way you do it in Mopal. You'll have to ask the patient to move their leg, lift their leg maybe. You'll have to rotate the pelvis above it. So the SI joint does move. It moves very little. It's held together very, very strongly with these ligaments. And of course, there's anterior ligaments. In this picture, you can also see the sacrococcygeal ligament, dorsal sacroiliac ligament or posterior sacroiliac ligament, sacrospinous ligaments, posterior sacroiliac ligaments, sacrotuberous ligaments, etc. A lot of ligaments in the low back. And here's from the front, you can see in the upper right of this, you can see the anterior sacroiliac ligaments and the sacrospinous ligaments and the sacrotuberous ligaments. The pubic symphysis, which isn't ligamentous, it's a disc pretty much. So the interesting picture, I think, is looking down from above, the lower left-hand picture. You can see those interosseous sacroiliac ligaments. They're really quite thick. The interosseous SI ligaments are the ones most commonly blamed for having some instability on a Category 2 patient. In a study done by Harrison and Troyanovich, that's the CBP chiropractors, the interosseous ligament is the thickest and strongest ligament in the SI joint, and it's the largest ligamentous joint in the body, and is actually much larger than where the ilium and sacrum actually meet each other, which is at the synovial part of the SI joint, which is more anterior and inferior. The synovial part is what we're concerned with on Category 2 patients. On Category 3 patients, we're concerned very much with the stability of the SI joint, which is very much a ligamentous issue. I'm going to let you review the research on all of these presentations on your own. But this one was interesting because these same guys did quite a good review of the anatomy of the SI joint and how people treat them, and they concluded that treatment of the SI joint is difficult. Correctly, they state that all known SI joint tests have questionable validity, and by themselves, that's true. What research has shown since this was published is that the more testing you do of the SI joint, the more likelihood there will be that you'll come up with a more accurate diagnosis of what's wrong with the SI joint. So if you combine a bunch of tests, you'll get better results. One test by itself isn't really enough. But they pointed out that pain-provoking tests, such as Faber-Patrick, if you put the leg in a Faber-Patrick position and it hurts, there's something wrong. So pain provocation tests are considered just about the gold standard these days for tests that indicate that a joint is dysfunctional, and that includes in the SI joint. So what we ought to do clinically is treat the instability. We ought to address the stability of the surrounding soft tissues of the SI joint. Well, that's exactly what we do in SOT with Category 2 blocking. And he states that sometimes you have to improve posture, and sometimes the patient needs maybe a heel lift or an arch support, and that's true. And I'm going to let you read the rest of this. These next couple of slides show that in the vast majority of cases, when you get a low back patient in your office complaining of low back pain, 9 times out of 10, it's going to be a Category 2 patient, not a Category 3. Category 3 would be primary disc. But all these studies that I'm showing you now all point to it's probably SI joint. Okay? Now, the last study is funny. It was done a long time ago, 90 years ago, almost 90 years ago. Leg length differences may be the prime cause of SI joint complaints. This was noted in an article or a book written by Dr. Cyriax. You've probably never heard of him. He was the very first medical orthopedist. He wrote the first book on orthopedics from a medical point of view, and he was considered a god among medical doctors when it came to understanding the mechanics of the human body. He thought that the short leg, was the cause of something. Chiropractors go exactly in the opposite direction. We feel that the short leg is a result of something else that we call subluxation. So this is a pretty good picture of the SI joint. At the top left, you see synovial part of the joint. It's responsible for motion, and it's associated with category 1 dysfunction. That would be A to P sway, bilateral symmetrical first rib, weakness on exhale, usually, heel tension. And the bottom arrow, that's the interosseous SI joint ligaments. That's the supportive anti-gravity ligaments, and that's category 2. This is an interesting study that some tests that you folks know that you do on new patients, they're reliable to varying degrees. For instance, SI joint motion seemed reliable, but the literature doesn't show that it's valid because the SI joint only moves 2 or 3 millimeters. I think that's a misunderstanding of what MoPAL really is. MoPAL is really the palpation of the muscular effort on the part of the body to fixate a joint secondary to some deeper issue. So when you find a right fixation on an SI joint, a lot of people would say, well, that joint used to be unstable and hypermobile, so the muscles tightened it up. And that's what you're feeling when you're doing motion palpation of the joint. The synovial part of the joint that's responsible for motion can only give it 2 or 3 millimeters. And I think lifting the leg gives you a lot more of a palpable indicator of fixation, and it's a heck of a lot more than 2 or 3 millimeters. Interestingly enough, the short leg agreed with what was seen on the standing x-rays. So when you do a leg check, prone or supine, it's probably going to agree with what's showing on the x-ray. And I'll let you read that one by yourself. So I came up with a neat test. I think it's neat. You do a supine leg check, and you have the patient tuck the chin. Keep the head on the table and just tuck the chin. If the supine short leg balances, chances are very, very likely you're dealing with an atlas subluxation. I would then go up and palpate atlas, find out what the listing is, and adjust it. I think this is an important thing to do before you use even the tests to determine if you can use SOT blocks. Atlas is the #1 compensator in the spine. It's capable of moving virtually in any direction. There's no disc between atlas and C2, and atlas has the most rotation of any spinal segment. It's right underneath the occiput. There's relatively very little atlanto-occipital motion, but there's a lot of atlantoaxial motion. So the vestibular mechanism probably uses the atlantoaxial joint as the last chance to get the head on straight. So fixations and subluxations of atlas are extremely common. And this is a very simple 2-second test. Just do a supine leg check. Patient, keep your head on the table and tuck your chin. Watch the legs balance. Again, it doesn't give you the listing, but it does tell you that you need to adjust atlas. Another area that I always check before I consider using blocks is fifth lumbar. I would have the patient, with her legs straight, lift her hips off the table. The most common lumbar misalignment is posteriority, just posteriority. So when you lift the hips, you're actually pulling the posteriority out of the low back. A side note that I noticed from doing leg checks for so many years is there seems to be only two areas of the spine that are capable of producing a supine short leg. The upper cervical area, the lumbosacral area, actually three areas, and the SI joint. Anything above L5 is very unlikely to result in a short leg. So if a patient comes into your office and they only have subluxation below C2 or above L5, they'll probably have balanced legs in the supine position. Prone, maybe not, but supine, that's all you'll ever find. Now, if a patient has a spondylo or an anterolisthesis, and it's the cause of the short leg, and it very well might be, the short leg will disappear. It'll balance out when they do a very slight sit-up. Don't worry about this. This was a poster that I presented at a research conference, the effect of CAT2 blocking on spinal ranges of motion. I'll go over that when I cover the research section of SOT. I'm with Charles Blum. He was the president of an SOT organization called SOTO USA. Really nice guy, very smart. He has done a lot of research in SOT. Trapezius fiber palpation is a palpation for trigger points in the upper traps. There's 7 fibers that you're going to palpate for, and there's a chart that goes with those fibers. What palpation of the upper traps enables you to do is determine where above the pelvis you're going to look for a need to adjust. And what you're actually finding are mechanical fixations that you would equally find just as accurately with Mopal. It would just take you 10 times longer. So trap fibers, boy, they save a lot of time. So here's the chart. And what you've got here is you've got a drawing of where you're going to palpate with your thumbs 1 through 7, and the cervicals, dorsals, and lumbars that are associated with trigger points that you would find at those areas. So you're going to need to memorize this chart to use trap fibers quickly in practice. So you should be able to say, without looking at the chart, oh, trap fiber 7, that's C7, T9, and L5. And you would determine which of those to adjust by palpatory pain at those levels. The patient's lying prone at the table. You're not going to Mopal, although you could. All you're going to look for is palpatory pain. So it's a real helpful thing, and I've got a video or two showing palpation of the trap fibers. This is our SOT roadmap to the spine. This material was sent to Arthur Guyton, the famous physiologist, by Desjarnette years ago, because although Dr. Desjarnette had come up with this chart and the method of palpation, he didn't really know why those levels were associated with those trigger points. And there's a story I can tell you a little bit later about what happened, supposedly. You don't need to worry about that at this point. The psoas muscle is a muscle that we always check on Category 2 patients. And we're going to show you how to check it. You're going to find the tight side. So we pull the arms overhead, and we're pulling pretty firmly, and we ask the patient, straighten your fingers out completely. And we look for the short arm. The patient's face up. We're grabbing the distal forearm. They're straightening their fingers out. We bring the palms together, and we find the short arm. And then the correction can be done a couple of different ways. There's a video that I'm going to show you either today or next week on the psoas procedure, but the video will be available in your week 3 and 4 weekly lesson folder online. It'll be either in week 3 or week 4. I'm dividing the category 2 material into 2 weeks at least because there's a lot of it. So we pull up, and the way I'm correcting the psoas is the palm, the heel actually, of my right hand is reaching across to the short arm side, the tight psoas side. The patient has the knee bent on that side. I'm stabilizing the SI joint with my left hand that actually runs underneath the patient's bent knee. I'm actively pushing the patient's right ilium towards their sacrum. I'm asking them to breathe in and out, and as they exhale, the heel of my right hand presses A to P and medial to lateral. That will help stretch out the psoas muscle on the patient's right side or short arm side. I would take an upper medial contact on the psoas, then I would repeat the procedure during exhalation on the middle of the psoas, where I would move my hand inferior about 2 inches and lateral about 1 inch, and again press A to P and medial to lateral, and then I would do it a third time just about medial to the ASIS, and then we would recheck and we would get balanced arms. I will also say that on the short psoas side, if you were to test the psoas muscle, it should come out weak. And I believe I've demonstrated that on my psoas video. The iliofemoral test is done supine. We turn the patient's feet in as far as they'll go. This is long axis hip joint rotation, internal rotation, which is the kind of rotation that medical research tells us we usually lose first. So in this picture, the patient's right foot won't turn in as far as the left foot. So I stand on the left side of the patient, opposite the side of involvement, just like psoas, and I reach across and get my fingers behind the patient's greater trochanter. I will then pull up with my fingers and ask the patient to turn his foot out against my resistance. We'll hold for 3 or 4 seconds, repeat 4 or 5 times, and then on retesting, the right foot will turn in just as far, if not further, than the left foot. So we're just removing some soft tissue restrictions before we block. I would certainly check iliofemoral and psoas before I blocked. The less resistance the patient has to lying on these corrective blocks, the better they'll work and the faster the arm fossa will become strong. So this is a picture of me using my thumbs, which I can do if the patient doesn't have really big feet or giant legs. If their legs are really sort of heavy, I grab the foot with 2 hands, turn it in, compare it to the other side. The side that won't turn in as far is the iliofemoral restriction side. In SOT, we don't use compressive leg checking. We use traction leg checking. So for category 2, we're always going to do a supine leg check. And I have my thumbs above the medial malleolus, and I'm tractioning down. I can keep the traction and bring my thumbs together to see the short leg. You'll be surprised to find that you can actually feel the short leg when you do it this way, when you don't contact the foot, the shoe rather. If you're contacting the shoe, it's really hard to feel a short leg. But when you're pulling on the patient, the short leg seems to have less stretch to it. And you're getting so much proprioceptive input from your fingers, your wrists, your elbow, and your shoulders that you'll be able to feel the short leg even with your eyes closed. So use traction when you do this. So I wrote here thumbs on the most medial aspect. You can do it that way. I think it's easier, actually, if you put your thumbs above the medial malleolus and pull down. You do want to maintain head and eye coordination. The vestibulospinal tracts enable you to maintain head-eye coordination and an upright posture and balance, and a conscious realization of spatial orientation and motion. They help stabilize the head by innervating the neck muscles, which helps with head coordination and eye motion. They control, very importantly, the anti-gravity extensor muscles in the leg that help maintain upright and balanced posture. Leg checks and posture analysis are based very much on the control through the vestibulospinal tract of muscle tone in the lower extremity. I'm just kidding when I say be able to draw this out and explain it for the next exam. With your eyes closed behind your back, make sure you use the correct color when you're drawing in the muscles and the sensory and motor for the brain. Just kidding. But for those of you who might be neuroheads, this is a really beautiful chart drawn out by Dr. Mark Pick. Years ago, 1997, he is very much into the anatomy and physiology of SOT. He's a diplomate neurologist. He's a fellow of the International College of International Craniopathic Society. And he knows an awful lot about how SOT works. So I think I'll end this part for this week, week 3, on this chart, which shows that this patient, who's a Category 2, has a PI on the right. He would have an upper inguinal fossa palpatory pain on the right. That would be worse on the right than the left. Medial knee pain, and we palpate that at the level of the top of the kneecap, halfway to the medial leg. And then when we do a supine leg check, that'll be the short leg side. And the AS ilium would be the LLL indicator. Lower fossa pain, lateral knee pain, long leg side. Combining the supine short leg with these trigger points ends up being just about pathognomonic of a PI and an AS. We only use Category 2 blocks when a patient shows this leg check with these indicators. Don't automatically use Category 2 blocks on all Category 2 patients. At best, you won't help them, but you can also hurt them. So don't do it. Also, don't use Category 2 blocks on any patient who doesn't have a weak arm fossa. This is shows you the relationship between the different muscles on the two sides of the body. So since palpatory pain is considered very reliable according to research studies, UMS and LLL would have to be the gold standard of Category 2 tests and pretty much the gold standard of determining PI or AS. It should agree with what you find using motion palpation, prone leg checks, palpating for edema, and looking at films. Thank you. There's another test that you can do before you start blocking. It's called sacral cup, and you can really do this on anyone at any time. Just check their gluteal muscle strength. Now, if you'll notice in the picture lower left, the patient is resisting. The doctor is pushing down by the ankle. Is this correct? It actually is. Are we crossing the knee joint? Yes, we are. Of course, when you check normal glutes, you're also crossing a joint. You're crossing the hip joint. The reason we purposely cross two joints here is so that we don't have to use much force. The glutes are very strong, and if you're too close to the butt when you check them, they could be weak and you'll never know it. So in the upper right-hand corner, there are these four dots, two on the right, two on the left. The upper dots are called the upper sacral cups. They're just lateral to the S1-2 spinous interspace, in the same area where you would adjust a PL or PR sacrum. And the lower cups are just lateral to the S3-4 spinous interspace, lower part of the sacrum. So what we do is we check the glutes prone, and if we find weak glutes, let's say on the right, the lower right-hand picture shows the doctor doing a rapid double thumb toggle. You can also use an activator. And where do you put your thumb? You put your thumb where you contacted upper or lower cup that caused the weak muscle to strengthen. So this is a quick stretch procedure done to the glutes on the weak side, either upper or lower, wherever the muscle strengthened. It's called sacral cup.